caboodle? Poodle cross, yeah, who has a history of a big splenic mass, and you can probably even see that through the skin. Incidental finding. We did a thoracic CT scan, found no evidence of secondary spread, and we did an abdominal CT scan and also saw no evidence of secondary spread. The mass is continuing to grow, and so we have decided to go ahead and take it out. If you haven't already done so, please subscribe to our channel. Make sure you turn on notifications so you'll get a ding on the phone the next time we live stream. So we are doing a midline approach here. Key things when you're doing an abdominal exploratory, make sure your incision is long enough. In male dogs, you want to go from the xiphoid to the prepuce, and in female dogs, you want to go from the xiphoid to a space about halfway between. We're getting a little bit light here. Might need to give some Alfax. Halfway between the umbilicus and the pubis. So the pubis is down here, so that's about halfway there. And then we've got Balfour retractors. We are going to remove the falciform, which just improves our visualization a little bit. We've got Jin, who's an emergency vet who's scrubbed in with us. And the dog's a little bit light, so often what happens is that we try to keep them light so the blood pressure is maintained, but then when we start operating, sometimes they wake up a little bit. Yeah, that's all right. So I found the linea there, and if I poke through the linea with my cautery right over the falciform, I don't have to worry about injuring or damaging any organs underneath. Okay, so that's falciform sitting there. She was spayed, and so I want to make sure also that there are no adhesions, like the urinary bladder or intestine or something like that. And then I'm going to remove the falciform. And there's that little membranous tissue that runs along the linea. You can see the splenic mass sitting right there. Some adhesions from the falciform to the splenic mass. Get chin to ligation. All right, so go ahead and just open that up right like that. And we'll lay it across here. Go ahead and close the jaws. Yep, and then push the button. Just let it'll beep when it's finished, and then pull the trigger to cut. That's great, and that's fine. So then release. So
push it again. Got it.
All right. So the anesthetic protocol is just ace-promazine, methadone, and then induction with Alfaxan. I'm not sure if they have Alfaxan in the U.S. or not. It's a lot like propofol. So when we put in our Balfour, we just want to make sure that we're not pinching any organs. Anything. It is a little bit small. So Balfour. That's all right. Once we get the spleen exteriorized, it'll be fine. Yeah. All right. So I am going to pull the spleen out first, assuming that I can exteriorize it. It does have a lot of attachments. The omentum is kind of adhered to it. Can I get a bigger valve port, please?
Very wobbly, not doing much.
So it's even adhered to the body wall in there. So when we break down, the adhesion, we just have to make sure that there isn't like a ureter or something in there. The other possibility is that we would go through the diaphragm inadvertently. Yeah, great. Yeah. So the ligature that we're using here, the Cayman, the advantage of the Cayman is that the jaw is a little bit longer. It does take a little bit longer to cauterize, that's the main problem with it, is that it takes a little bit longer to cauterize. Also, you can't dissect or use the instrument for dissection quite as well as you can with the proper ligature. But it works well, and it's what we have available. And so I certainly, given that I have done many splenectomies without having any kind of vessel sealing device, I certainly am not going to complain. All right, so we've got a little better view here. Not sure if you guys can see the adhesion in there. I don't think you'd be able to see it on the camera. So I need to break that down, and just to be aware that, can I get cautery turned down to maybe, as in coag, turned down to 20? Got it?
Yep.
So usually splenic masses don't form adhesions, in my experience. We do have the dog on a ventilator in case we go through the diaphragm. Preference would be not to. So I thought this was going to be a very straightforward splenectomy, but what I'll do is I'll probably break down this adhesion and then pack it off with a laparotomy sponge to address the bleeding. All right, so we've got the spleen there. I'm going to pack off. Mia, we've got a sponge in the abdomen.
You've got a sponge.
I've got a sponge in the abdomen, yeah, so just to remind me.
Yeah.
Okay, so then we've got some guts, some intestines close by. We've got the short gastric vessels there as well.
Hey.
So, just a little bit trickier than your average splenectomy. So far, I'm not concerned about my ability to get it out. So you just go until it stops beeping.
Yep.
So we can definitely just ligate the short gastric vessels. There's no issue with that at all as far as blood supply to the stomach. Jen, we may just get another, can we get some saline, please? So I might have you just retract on that. So I just need to make sure that I'm not taking out part of the stomach. So again, these are the short gastrics. And there's a question about whether I'll take a liver biopsy. Answer is probably.
Did you end up getting drugs out for methadone out?
Metoclopramide?
Methadone.
No, it wasn't due until for a while. Is it due?
That's fine if you might. The dog is fine.
Thank you. Is it for Jeff? Max. That's fine.
Yeah. Thank you. I'm just trying to make sure that I keep enough distance between the stomach and the cautery. Cauterize through that, I reckon. And if I need to take out some of the stomach, I will. But if I can avoid it, I will as well.
Of course, yeah, 100%.
The other thing we're going to encounter as we get deeper here is the pancreas. That's going to be a bit of a trick there.
Bit of touch. Much better.
Yep. Thank you. Can I get one of my little needle cautery tips? Is it releasing itself a little bit? And attack that off there. And I'll attack it from this direction. Just hand that off to Jen if you could. So I know I've got a couple of questions on the stream, but I can't get to them just yet because I'm concentrating. So, all right, so what I'm going to do here is I've got this little needle cautery tip, and I'm going to bend it into a right angle like that. And I'm going to use that for dissection. So just come. My cautery is set on 20 and 20. I know I had a question about that. At this point in the surgery, I'm not alarmed by anything. It'd be nice if this was a little bit less attached, but I still feel confident that I'll be able to get it out. Make sure that there's no stomach in there. So I certainly have done a lot of these without ligature. And you basically, anything that you do with the ligature, you'd have to do just with a pair of hemostats and then cut and ligate. So pancreas is very close here. All right, so what we'll do is we'll just get Jim to retract up here. So pancreas is right in there. So I'm just going to be, I'm going to kind of carefully try to dissect some of this tissue off. We've got the big pancreatic vessels here coming off probably the left gastric. Big vessel deep to that. Really big vessel. The other concern would be the portal vein. So I need to make sure that so that's portal vein right there, right? That might be coming off the splenic. Let me just lift up the duodenum and see if I can see portal vein separate from the tumor, because if we damage the portal vein, we are pretty much stuffed. All right, so portal vein is right there. So the majority of the portal vein is intact. So I think that's just the splenic vein there. Big vein sitting right there with the pancreas attached to it. Now I can amputate the left limb of the pancreas without any problem at all. I'm trying to avoid touching the pancreas with my forceps. So that's that pancreatic vessel right there. Goodness. So that is a big, scary vessel right there. I just need to make sure it's not something critical. Come around this side here. I beg your pardon?
So Jess said that 2:30 to 3 o'clock they'll come get her.
Yeah.
But she's saying that
Max is already scheduled at 2:30, I think.
no, Max was no, they changed it. They changed it. Yeah.
So they just may have to wait a little bit.
Yeah. Okay. She's not on Medicam at the moment. But on Melvin's discharge sheet he's got.
Okay, so we'll get her some Metacam as well.
We'll just send her home.
Yeah.
Okay.
So is that spleen or is that just vessel
Yeah,
there?
looks like a vessel.
Okay. So that's separate from the pancreas. So that's just the big splenic
Oh, my
vein right
goodness.
there. Right, so that's too big for us to ligashore.
Yeah.
So I'm going to do something very risky here because I don't want to ligate them together. I don't want to ligate the splenic artery and vein together because you can form an AV fistula. All right, can I please get some 2O PDS? So the cautery is set on 30 for cut and 20 for 30 for cut, 20 for coag. And if you don't have ligashore, you just have to dissect slowly and carefully. I'm just going to zoom out a little bit so you can see a little better what's going on here. And do like we used to do before we had ligashore. All right, so because this is a vein, I can just single ligate it, but I have to be really careful that I don't rupture or avulse that vessel. Cut that off, please. I'm just going to clamp that and then cut below it.
She still has some diarrhea, so should we just maybe hold off on sending her home for the minute?
No, we can send her home, but just don't put her on meloxicam.
Okay. No, as in like, I said, should we not send her home on the clock?
Oh, yeah.
Okay.
Yeah, thank you. So now we've got the splenic artery. That's probably small enough to ligashore, but what I'll do is I will ligate it and then I'll ligashore it distal. we're in great shape now. Just come through here. Exclude that lap sponge. Okay, so let's show the mass there. So that's the mass we've taken out. That's a big one. All right. So now we've got that out, we can see much better. I'm going to take up my lap sponge so that bleeding area close to the diaphragm has stopped.
Yep.
And I'm just making sure, so that is on the diaphragm, just making sure that we haven't perforated it. Diaphragm's still holding suction really nicely, so I'm going to close that area just in case. Can you come around this side?
Sure.
Can I please have some 3O PDS? So you guys can't see it, but I've got a partial thickness rent in the diaphragm. Just pull that down a little bit lower like that. Sorry you guys can't see what I'm doing in here. So it's just a little partial thickness tear in the diaphragm that was created when I removed the adhesion of the mass. Interesting to see what this comes back on histopath.
It's very aggressive.
Yeah. Try not to get your finger there.
Almost like doing a pexy, gastropexy.
Yeah.
Partial thickness in the diaphragm. Not diaphragm, but it shouldn't be in diaphragm.
Yeah, the abdominal
Yeah.
wall. Did one with Malcolm yesterday with that Great Dane. We pexied it.
Yeah.
All right, so now we'll just do a quick exploratory. So the liver, a little irregularity there. Do we have a skin punch? Skin punch biopsy? Yeah, yeah. I know I ordered them. They're in here somewhere, like in the, yeah. So we'll take a biopsy of that. The gallbladder is soft, easily expressible. Colon has some poo in it. Rest of the stomach looks good. Duodenum, pancreas, coming around the caudal duodenal flexure. Get a look at the mesenteric lymph nodes as well, just given the fact that we've got this big mass, potentially aggressive. so jejunum. Let's run the bowel. Cecum, colon, kidney, adrenal gland. That all looks pretty good. I didn't get a look at the other adrenal gland or get a feel of it so I can see it. You normally can't see it, but I can see it and feel it, so that's okay. All right, so we're just waiting for a biopsy punch. Take a liver biopsy right there. So that looks a little bit abnormal to me. Just waiting for that biopsy punch. They'll be in there, probably on the shelves up at the top. That ligature gets very crusty. I don't know if you guys can see that, how crusty it is. I might step out for a minute and see if I can help them find it. Stores, stuff. So those are needles there. Skin stapler, sterile stapler, plates. Look in the, no, it wouldn't be in the drawers there. Maybe in that cupboard. No, that's pouches. Huh, so weird. I know we've got them. I don't think so, but I'm not sure. Okay, that's all right. I'll just, what we'll do is we'll get some Liostip, and I'll just take a shave of it. So get the collagen stuff. And I'll just do a little shave of the top of it. We can't find our biopsy punches. So, can you grab some scissors, please, and just cut that off? Yeah. Thank you. So we'll get that in formalin. And I'll just lay some Liostip on top of it. We probably need to order some more of that as well. If you can check to see how much we've got. Can you open that up for me, please? So this is purified bovine collagen, which has excellent coagulative properties. Where did I put my DeBakey's? It's almost stopped bleeding already. So can we get some warm saline, please? Yeah. That is so bizarre. I'm struggling here. There must be a hole in this.
No, cap.
That would explain it?
Yep. Easy fix, at least.
Alright, so we'll just suction out that. I might have you, yeah, we'll just have you pour it in here. That's great. Okay. So the survival for splenectomy depends on what the pathology is. If it's a hemangiosarcoma, the median survival time without chemo is only about 2 months, and with chemo is about 6 months. If it's like a sarcoma, probably not hemangiosarcoma, but just a soft tissue sarcoma, you're probably talking about a couple of years. If it's like a benign myelolipoma or hematoma or something like that, then the surgery should be curative. Just count our sponges if we could, please, to make sure we've gotten everything out.
1, 2, 3, 4. Hold on. Comes in a pack of 5?
Yeah.
1, 2, 3, 4, 5.
Great. All right, so we've done our sponge count post-op, or post-exploratory, so now we'll just do a routine closure to make sure that you're getting the linea. It was a little bit more challenging of a splenectomy than I'm used to. Similar to Malcolm's a mental infarct yesterday. And if you guys stay tuned, after I'm finished, I will go back through the questions and make sure that I've answered everything. So if you asked a question and I didn't answer it, just hang tight, and when I'm finished, I'll go back through and make sure. Make sure my knots, because I'm doing simple continuous, make sure my knots are secure at the ends. All right. Jen, I'm pretty good now. You're welcome to stay, but if you need to do other stuff.
No worries.
Thank you so much.
Thank you very much.
So it's so nice to be working in an emergency center and specialist hospital again, because it means that we have overnight care with vets on premises. We've got a CT scanner on site, and I can ask opinions of other vets about post-op care. I've got a great teammate, Malcolm Jack, who's my other specialist surgeon. Got a great team of nurses, Mia, Tiana, Aaron, and hopefully Tegan will come on board soon, permanently, but we'll see. Oh, great. So Dee is also coming. Yeah, so she's from the U.S. I think she might be from Maine. So there's a question, I think, about why I changed my protocol, and I assume you're talking about using alfaxan instead of propofol. Just alfaxan was not available at my other hospital, so that's always been my preference. There have been some problems with increased risk of infection associated with propofol because it's in that milky consistency that without preservatives, which means that sometimes you can get bacteria growing in the propofol bottle. Otherwise, I think they're fairly similar in activity. Propofol is the one that Michael Jackson died from overdosing on. Yeah. He was just basically on a constant, I think basically a drip of propofol all the time. I think I just saw somebody say goodnight. So I imagine you're probably in the U.S. If you're going to bed now, you're probably in the U.S. If you're waking up, you might be in Europe. Since moving to Australia, I'm much more aware of the world time zones, and then since I started live streaming, just seeing people's comments and stuff, I'm much more aware of what time it is in other parts of the world. If you're getting woken up in the middle of the night, you can always turn your notifications off. I know you don't want to miss a live stream, but I hear about people like in Ukraine up at 3 o'clock in the morning watching YouTube.
They're just sitting there waiting for
Yeah.
notification.
I have to come up with a collective name for the people that watch our YouTube channel.
Oh,
you guys are welcome. If you can think of any good names, I should have a ballot or something, or a survey or a contest to see who can come up with the best name, collective name for Vet Dojo and Vetalign fans.
I feel like Erin could come up with something.
Yeah.
It's not going to be.
Like Taylor Swift has Swifties.
Yeah, exactly. Yeah,
Dylan just replied, I never want to miss a live stream. Dylan is one of our oldest fans. We'll call you Swifties for the moment, the time being, until we come up with another. I think I've been talking to Dylan for about 8 years or something. Dylan now has started a residency. I think he did his internship at vet school in maybe Texas, and then has started his residency, surgical residency. In Brazil, it's 11 o'clock at night.
you just know that from memory now.
Now I can see. I'm cheating. All right, so that's the surgery. So I'm just going to go to the live stream, the streamer, and see if I've missed any comments or questions. So good night from Leonardo. Hello from Brazil, from Tiago. This dog came in for, I think, gastrointestinal signs, and then the splenic mass was found incidentally. Hi, Taiwan. Let's see. I set my diathermy on about 20 and 20 or 30 and 30. Protocol is the same except for the alfaxan instead of propofol. Hi, Argentina. We did a liver biopsy. This is a big tumor. Hi, Malaysia. First year vet student, interested in small animal surgery. So what did I do during my summers during vet school, and do I wish I did anything different? I worked at a really good general practice at home during my summers, except for one summer I went to Colorado and worked at a zoo, and that pretty much just confirmed to me that I didn't want to be a zoo vet. So too many politics. We don't do a lignocaine CRI prophylactically with our splenectomies. They are prone to arrhythmias, and the presence of an arrhythmia is prognostic in that 90% of dogs with an arrhythmia after surgery are going to have malignant disease, whereas only 10% of dogs without an arrhythmia have malignant disease. That was a study done by Dominic Marino back in like 1994, something like that. So I've told you the anesthetic protocol. Hi, Baltimore, Maryland. Hi, Jacksonville, Florida. Hi, Florence, Alabama. Tampa, Florida. Egypt, South Korea, and Brazil. So it's really lovely to hear from everybody. I love hearing from all the different places in the world you're watching from, and all the great questions. So again, if you can come up with a great name for all of our supporters, that would be amazing. Somebody in Egypt is watching at 4:40 a.m. That's some dedication. That's a dedicated Swiftie. So anyway, send me a message if you've got an idea for a name, a collective name for everybody. Anyway, great talking to you guys, and we will see you again soon.